Just one more minute. Yeah, you can start now.
Good afternoon, one and all. On the behalf of Department of Psychiatry, AIIMS Jodhpur, I, Dr. Pranshu Singh, invite all those present who have joined the program for this program. As we all know, 31st May is observed as World No Tobacco Day. Tobacco dependence remains a global health menace, while tobacco is one of the most commonly used psychoactive substances worldwide. As a department, from time to time, under the leadership of our head of department, Dr. Naresh Nebinani, we have tried to raise awareness regarding important mental health issues. This is one such endeavor to increase awareness regarding tobacco dependence and its treatment. So without much ado, I'd like to invite our esteemed director, sir, Professor Sanjeev Mishra, for the welcome address. Your support and guidance has been crucial in the success of our department as well as that of the institution, sir. I welcome you, sir, for the address.
Good afternoon, everyone. Dr. Naresh Nebinani, all the faculty from the Department of Psychiatry, all the interns and the students who have joined this program online. As we all know that tomorrow is the World No Tobacco Day, and they have the Department of Psychiatry is organized on the eve of the World No Tobacco Day this seminar and discussion about management of tobacco dependence. So we keep talking about the ill effects of tobacco, but when we come down to how for somebody to kick off this habit and kick this habit, so that area still needs a lot of awareness. People want to leave tobacco, but they don't know how to really go about it. And I'm sure that this will definitely create awareness among the doctors here who have joined, and they can be the ambassadors to advise people how to go about it. There is definitely a great scope for developing this area and understanding how it is done, because after all, tobacco generates chemicals and there is psychological dependence, which is craving and is there. There are medications, there are feedback mechanisms, there are so many things which is there. And the dependence of tobacco is so much that when we see patients, when we've operated for cancer, novel cancer, they go back to smoking or chewing tobacco because it's there, and the pharmacological means and the psychological methods and interventions can really help them in overcoming this. So again, I must congratulate everybody in the department and Dr. Naresh, Dr. Navratan Sukar, Dr. Preeti, Dr. Mukesh for taking this initiative to organize this meeting and on tobacco dependence. And thank you for asking me to be part of it. And I'm sure that all of us benefit. And at the end of it, please do ask as many questions as you can, because that is a very important thing in the presentation, that more the questions, the things become clearer at the end of it. So thank you, Dr. Naresh, and over to Dr. Pranshu Singh.
Thank you so much, sir. I'll now like to invite our Honorable Head of Department, Dr. Naresh Nebinani, to introduce our speakers for today and also to enlighten us more upon today's topic. Over to you, sir.
Good afternoon, all. And special thanks to Director Sir for guiding and always motivating us to create more and more awareness.
Shift it here.
Would you please? Thank you all delegates to be present on the day when we are all here to celebrate the eve of No Tobacco Day. Special thanks to our respected Director Sir for guiding and motivating us to create more and more awareness to all the gap areas to have better healthcare facilities and attitude of the people to get the treatment on time. As we see today, we have designed this program to address a couple of things to help out the population, people coming with tobacco use disorder. And the program is designed by my colleague, Dr. Preeti, and other dear colleagues, Dr. Navratan, Dr. Mukesh, and Dr. Pratibha, Dr. Anish. All are the team, along with Dr. Tanu and Ms. Lakshmi, with the whole energetic senior residents who are helping in conducting this program. Doctors are directly dealing with these patients in different places and different clinics, and yes, in community. So we thought to try to fill this gap to tell them how to assess these patients and how to address their problems. Why so? Because as we have seen, most of us are aware about GETS-2 study, which was the Global Adult Tobacco Survey of India, which was conducted in 2016 and 17. And once the population of about 74,000 people in different states were assessed, and it was found that about 28% of them are currently using tobacco either in a smoking form or a smokeless form. So the magnitude is pretty high. And once we have tried to see this in light, then in our state is almost slightly equal or slightly lesser than the national prevalence. But once we see the India, then the trend is more is smokeless tobacco than the smoking form, almost 2 times more than smoking form compared to the high income countries. But once we see in Rajasthan, then it is both the things, smoking and smokeless is almost equal in terms of proportion of people who are consuming this substance. While in high income countries, definitely smoking is more visible and talked about as a problem and as a behavior. But here we see about 90% of them are aware about the health related consequences of these substance, but still they are using. In this study, only people have found that about 1/3 of them had some quit attempt in last 1 year. 1/3 of all of us who are not consuming tobacco supposedly are also affected with secondhand smoking. But one figure was also there that about 50% of people have thought to reduce or stop the substance, or they are interested to try on this. But again, many times we find the difficulties because of the busy clinic schedules and lack of capacity and tech skills. Most of the healthcare professionals are not able to handle this in their respective clinics. That's why the term has come opportunistic screening. So whenever they are in any clinic, every one of us, all the medical professionals, all the medical interns should be equipped how to address, how to assess this problem. Then definitely we can fill the gap in our practice, and then the problems will be much lesser. My colleague Dr. Preeti and Dr. Dr. Navratan, both of them are with us to deliver the talk. And I'm sorry to say, as Professor Sonali Janji ma'am was going to deliver the talk, but because of some other unavoidable circumstances, she's not with us to deliver this talk. Dr. Preeti and Dr. Navratan will address about the assessment and medical management. Dr. Navratan will cover this part, and the psychosocial management will be covered by Dr. Preeti. Both are here and both are very much focused and energetic to cater for the better services in the substance use, and preferably today we'll be talking about the tobacco. So here we are with all the energy, efforts, and definitely we expect that it is going to generate a lot of questions and knowledge base, and maybe from tomorrow onwards we all will be much equipped to handle these problems in our clinics and in community. Thank you very much. Over to Dr. Pranshu.
I'll now like to invite our first speaker for today, Dr. Preeti ma'am, for her presentation.
Pranshu, it is Dr. Navratan, sorry.
Dr. Navratan sir for the first presentation. I'm sorry, first is Dr. Navratan.
Am I audible?
Yes, sir.
Sir, your video is not visible.
Zoom पे Dr. Navrat.
So can you make it full screen?
Is it okay?
Yeah, fine, sir.
Okay. So thank you all the participants for joining this today's seminar. So I want to thank first our HOD who has provided me opportunity to present on this topic. So I'll be covering first part, that is assessment and pharmacological management of tobacco dependence, and second part will be covered by Dr. Preeti. So as we all know, as per the GATT survey, tobacco is the most commonly used substance in the India. And among the tobacco, smokeless tobacco is more common than the smoking form. Every fifth adult uses smokeless tobacco, and every 10th adult is smoking the tobacco. So if we talk about the smoke preparation, these are the three common preparation available, that is BD, cigarette and hookah. And in the smokeless tobacco, there are various forms. If the tobacco is alone, then it is available in snuff, Gudaku, Gul, Mishri, tobacco with other components like kheni, jarda, bitter liquids with tobacco in gutka and mawa and pan masala. So these are various preparation available in the market. So all these products contain a similar psychoactive component, that is nicotine. So how it works in addiction? So nicotine stimulates a receptor that is located in the ventral tegmental area in a midbrain. So that will release dopamine in the reward pathway, and it will provide pleasurable feeling and give a high to the person who is taking tobacco. So this high will lead to repeat administration of that tobacco, and gradually it will lead to development of tolerance. So it's a kind of addiction, just not just a kind of bad habit. It's a disorder. In the same manner, if a patient will discontinue the substance or tobacco, it will lead to withdrawal symptoms. That will again lead to repeat administration of the tobacco to improve the withdrawal symptoms. So there are certain myths in the community as well as in the clinician. So first we will talk about those common myths. So we will deal with those myths, and we have to psychoeducate the patients regarding those myths. So there are common myths like tobacco use is a bad habit or a character flaw, although it's a kind of disorder. Tobacco use is less harmful than the other drug of abuse. So it's a very well known public health problem. It will lead to multiple morbidities and mortality. So it is not less harmful than the other drug of abuse. Smokeless tobacco or gutka like kheni is a safe to use. It is commonly believed in the population, although it is not safe. It will lead to multiple problems that is related to oral cavity or oral route. And smokeless tobacco like chewing gutka kheni is not as addictive as smoking. But as per the research, it is as addictive as the smoking. Act on the similar reward pathway. BD and hookah are less harmful than the cigarette smoking, but it is not. Taking 2 or 3 cigarettes or a smaller amount of smokeless tobacco per day is not harmful. But when this use become harmful and person become dependent on the tobacco, no one knows. So no amount is safe if we talk about the tobacco. Using tobacco in a personal matter, hence it should not be discussed during the clinical care. Tobacco is a very huge public health problem, so it should be discussed in any patient who came for the consultation, whether he or she is taking tobacco or not. One can quit smoking with a strong willpower alone. So I can quit anytime. So this kind of belief is quite common in the population. Although strong willpower is required for the treatment, but only strong willpower is not enough. There are certain other counseling or non-pharmacological means and medical means to treat the tobacco dependence. I have too much difficulties in quitting, hence I will unable to quit. So these kind of difficulties are quite common during the initial phase, that is withdrawal symptoms. There are certain medication by which you can get rid of those withdrawal symptoms. Once an addict, always an addict. It is quite common phenomena in personal as well as in clinician. ये कभी छोड़ नहीं सकता, but there is a treatment for the tobacco dependence. So we have to proceed in two basic heading. One is assessment and second one is management. In the assessment, there are two assessment is required. One is for the assessment of nicotine dependence And second one is assessment of the motivation, whether the person want to quit or not. So there are certain indicator or marker that you can identify in your patient whether this patient is addicted or not. So if a person is taking tobacco or smoking in a higher quantity, taking tobacco within half an hour of waking up in the morning, experience withdrawal symptoms whenever he or she try to stop, keep smoking or chewing despite health related issues, and had multiple failed quit attempts. These are certain indicators that the person in front of you are become addicted on tobacco. So in the assessment, there is an intake assessment pro forma in which you can assess the various socio-demographic details like age, gender, and then specifically about the tobacco, like type of tobacco, amount and frequency, age at initiation and duration of use, presence of withdrawal symptoms or not, interest, person is whether interested in quitting or not, any past quit attempts, whether these quit attempts are medically managed or not, and their duration, the quit attempt duration. So what was the reason for tobacco use, environment, triggers, reason for quitting, all those things need to be assessed in detail. In addition to this assessment, the knowledge about the tobacco related harms and benefits should be discussed. Presence of comorbid physical and surgical condition need to be addressed. So if we talk about the International Classification of Disease 11th version, in this version, nicotine dependence, there are certain criteria or characteristics features. Among these characteristics features, the strong internal drive is an essential criteria. The strong internal drive to use nicotine, which is manifested by impaired ability to control use, increasing the priority given to use over other activities, and persistence of use despite the harm or negative consequences. So it is an essential criteria. Another criteria is urge or craving to use nicotine. And third criteria is physiological feature of dependence, that is tolerance and withdrawal features. Duration is same, that is a 12-month of period. So if we talk about the nicotine withdrawal symptoms, ICD-11 mentions certain withdrawal symptoms of the nicotine. These are certain mood symptoms like dysphoric, irritability, frustration, anxiety, anger, insomnia. There is a difficulty in concentration, restlessness, bradycardia, increased appetite, and weight gain, along with craving. These are certain common withdrawal symptoms of nicotine. There are certain other physical symptoms of nicotine withdrawal that are increased cough or mouth ulceration. So how to measure dependence in routine clinical practice? So if a patient came to you, there is a common method, that is one scale is available for both the form smoking as well as smokeless tobacco, Ferguson test for nicotine dependence. It will take only 2 to 5 minutes. It is a standard instrument for assessing the intensity of physical addiction to nicotine. So it will give you a score that ranges from 0 to 2 is equal to very low dependence, 3 to 4 is a low dependence, 5 is a medium dependence, 6 to 7 is a high dependence, and 8 to 10 is a very high dependence. So generally in the treatment, we will take patient preference, but if it is in the range of high to very high dependence, those group of patients will be considered for the nicotine replacement therapy. So this is a 6 questionnaire in FTND. You can see this on a Google. And second assessment, it should be on the motivation. You can directly ask the patient about the reason for whether he or she want to quit or not. What are the common reason for which he or she want to quit it. So on the basis of these direct questioning, we can assess the motivation is fair or superficial. Other than the direct questioning or clinical questioning, there is a skill that is readiness to change questionnaire. From this questionnaire, you can assess the stages of change. There are 5 stages: pre-contemplation, contemplation, preparation, action, and maintenance stage. So this will be discussed by Dr. Preeti in detail. So these are 2 methods by which we can assess the motivation to quit the tobacco. So after the assessment, I'm going to discuss about the management. So tobacco dependence is broadly divided in 2 parts, physiological and behavioral. For the physiological symptoms, that is tolerance and withdrawal, so there are some medication which are there which will be helpful for cessation. For for the behavioral symptoms like the habit of using tobacco, there are certain behavioral change program are there that will be discussed by Dr. Priti. So evidence-based intervention are both pharmacological and behavioral intervention and combination of both pharmacological and behavioral intervention. So I'll be discuss about the pharmacological intervention. So there are 3 first-line pharmacotherapies available in market, that is nicotine replacement therapy, bupropion sustained release preparation, and varenicline. On account of the addictive nature of the nicotine, only 3 to 5% of the tobacco users are able to quit without any help. Pharmacotherapy has been shown to double or triple the chances of quitting. So, if a patient want to take any pharmacotherapy, never hesitate to prescribe. So, for the patient who is willing to quit, we can help that patient to develop a quit plan, to provide a practical counseling and recommend pharmacotherapy, and to arrange further follow-ups. How to develop a quit plan, that is a mnemonic can be learned as a STAR. You have to set a quit date. Ideally, it should not be long. It should be within 2 weeks period. You have to tell the family, friends, or nearby co-workers about the quitting decision, and we have to request them to understand and to provide the support. Person should anticipate certain challenges to the upcoming quit challenges, upcoming quit attempts, and to remove all the tobacco products and related paraphernalia from the nearby environment. So this is about the how we can develop a quit plan. Who should be prescribed medicine? So generally, pharmacological intervention are recommended for all the tobacco users who is attempting to quit, unless there is a medical contraindication, especially the tobacco users with high or very high level of dependence and multiple previous failed abstinent attempts, and tobacco users unable to abstain with brief intervention. They can be put on pharmacotherapy. On the opposite side, like quit attempts without pharmacotherapy, especially in light tobacco users, that is less than 10 cigarettes or BD per day or 1 packet of smokeless tobacco per day, are initially preferred for brief intervention or non-pharmacological measures. However, if these users, like low dependence user, prefer to use pharmacotherapy, we have to provide pharmacotherapy in those group of patients also. So as I discussed, there are 3 recommended pharmacotherapy: NRT, bupropion SR, and varenicline. I'll be discussing one by one. First, I will discuss about nicotine replacement therapy. So 3 common preparation available nearby us is nicotine gum, nicotine patch, and nicotine lozenges. Nicotine gum is available in 2 mg and 4 mg preparation. Similarly, nicotine lozenges in 2 mg, 4 mg. And there are 2 mode of delivery of nicotine patch. One is 24-hour delivery and 16-hour delivery. 24-hour delivery nicotine patches are available in 3 forms, that is 7 mg, 14 mg, and 21 mg. However, 16 mg preparation are available in 5, 10, and 15 mg formulation. So nicotine gum, how it works and how to use those nicotine gums. So nicotine gum delivers the nicotine through the lining of mouth. So we have to educate the patient about the chew and park method, that I will discuss on next slide. Nicotine lozenge, it delivers the nicotine through the lining of the mouth. It allows to dissolve slowly in the mouth. And nicotine patch, it delivers the nicotine through the skin, and that nicotine patch should be applied above the waist and below the neck, and it should be rotated daily to the different side. So first I will be discussing about the nicotine gums. So in the all the form of NRT, quit date is on the same day of administration of NRT. So those the patient who are taking 1 to 24 cigarettes or BD per day, 2 milligram preparation of gum can be given. 9 to 16 piece per day can be given for the period of 12 weeks. And for the patient who are taking more than 24 or more than 25 or equal to 25 cigarettes or BD per day, 4 milligram preparation should be used, and 9 to 16 pieces can be used per day for next 12 weeks. So duration of treatment at least should be given for 12 weeks, followed by gradual reduction. For strongly dependent user, longer period of NRT can be given to prevent the relapse. So, what is the chew and park method? In the chew and park method, chew the gum slowly until the taste of nicotine is felt in the mouth. Stop chewing and place, that is park, the gum between the cheek and gum. That is essential for the absorption of the nicotine through the buccal mucosa. When the taste fades after the few minutes, you can again start chewing nicotine gum and repeat this procedure for next 30 minutes. Specific instruction should be given to the patient, like they should avoid eating or drinking for at least 15 minutes before or during the nicotine gum chewing to prevent the reduced absorption of the nicotine. Then how to weaning from the nicotine gums? Tapering can be considered after a period of 8 to 12 weeks. Decrease the total number of gums used by patient like one piece in every 4 to 7 days can be decreased. Increase the duration between the use of nicotine gum pieces. Like initially every 1 to 2 hours, then 2 to 3 hours, 4 hours, the duration can be increased. If using 4 milligram of gum, replace it with the 2 milligram gum and apply any of the aforesaid steps. Consider stopping the use of gum when the craving for nicotine is satisfied by chewing just 1 or 2 pieces of gum per day. So this is a criteria where you can consider stopping of nicotine gums. There are certain side effects. The common side effects that are mentioned by the patient, like nausea, hiccups, burning sensation. So in that way, you can properly psychoeducate the patient about the chew and park method. So these side effects can be minimized. Second is nicotine lozenges. This is also available in 2 and 4 milligram doses. It should be slowly sucked until the strong taste is noticed, and then rest the lozenges between the cheek and gum, and then repeat sucking. Each lozenges will take around 30 minutes to consume. Wait until the taste fades and use only 1 tablet at a time. Maximum is do not exceed more than 15 lozenges a day. So how to decide a dosing? So 1 lozenge is every 1 to 2 hourly for first to 6 weeks, then every 2 to 4 hourly, then for next 7 to 9 weeks, and then 4 to 8 hourly for 10th to 12th of weeks. Third preparation is a nicotine patch. So I am here discussing about the 24-hour delivery system that is available in 3 preparation: 21 mg, 14 mg, and 7 mg. The person who is using more than 20 cigarettes, we can put that patient on 21 milligram of patch once daily for a first to 4th week. Then we can shift this patient from 5th to 8th week on 14 mg preparation, then from 9th to 12th week on 7th mg preparation. The patient who is taking less than or equal to 20 cigarettes, we can start directly from the 14 mg preparation for first to 4th week, and then from 5th to 12th week, 7 mg preparation. So how to use nicotine patch? It should be placed new patch on every day, relatively hairless location, typically between the neck and waist. It should be rotated, side should be rotated every day to reduce the local skin irritation. The major side effects are rashes, and with 24-hour wearing preparation, insomnia is common. No self-titration, craving, withdrawal like other NRT routes is with nicotine patch. Because of this reason, patients generally prefer nicotine patch because it should be taken once in a day. It can be used on dental problems, and combining patch plus gum, lozenges, inhaler in high-risk situation increase the quit rates by another 5 to 10%. So that means the nicotine replacement therapies can be used in combinations. Using NRT will take in less nicotine and at the much slower rate than when smoking. So it will lead to no high concentration of nicotine that is characteristic of smoking. Overall nicotine dose is 1/3 to half in cigarettes, and there are no toxic tar and gas phases in NRTs. There are certain contraindications with NRT like gastric ulcer, acute MI, unstable angina, severe cardiac arrhythmia, recent CVA, uncontrolled hypertension, and age less than 18 years of age. So do consider those contraindication. The second pharmacological intervention is bupropion SR, that is sustained release bupropion. It can affect the level of neurotransmitter. It is a basically antidepressant, that is NDRA, norepinephrine dopamine reuptake inhibitor. So it affects these neurotransmitter and affecting the urge to smoke, and lessen the some withdrawal symptoms that are characteristics of tobacco, like anxiety, irritability, and depression. There are two common, like in SR preparation, 150 milligram dose is available. It helps smokers to stop smoking and reduce the withdrawal symptoms. So for the bupropion, we have to decide a quit date on the 7th day. We have to start bupropion on day 1 to 6, 150 mg, 1 tablet a day. And on the 7th day, that is a quit day, the tablet doses can be increased from 150 milligram OD to BD for next 12 weeks. So who can use the bupropion? All the adult smoker except those who are pregnant or breastfeeding, concomitant with medication or medical condition known to lower the seizure threshold, because it is quite associated, seizure is associated with bupropion, and severe hepatic cirrhosis. These are certain contraindication where bupropion should not be used. There are certain side effects or warning, like side effects that are common with bupropion are insomnia, dryness of mouth, nausea, nervousness, difficulty in concentration, rash, headache. Specific it should be cautiously used or contraindicated in patient with seizure disorder. Third medication is varenicline. So it's an alpha 4 beta 2 receptor partial nicotine agonist. So it acts on both way by partly blocking. It reduces the pleasurable effect of smoking and potentially the risk of full relapse after the temporary relapse. And by partial stimulating effect, it relieves the craving and withdrawal symptom. So how to use varenicline? So tablet is available in two preparation, 0.5 mg and 1 mg. From day 1 to 3, it should be start with 0.5 mg OD. From day 4 to 7, 0.5 mg BD. And from day 8, that is quit date, you have to give a full dose 1 mg BD for next 12 weeks. All the adult smoker except those with the severe renal impairment, because it passes through the kidneys, and it should not be used in pregnant or breastfeeding women. There are certain side effects, like common side effects are nausea, sleep disturbances. There have been reports of depressed mood, agitation, change in behavior, and suicidal ideation with this drug. So always look for those symptoms in your patient who are on varenicline. So varenicline overall help smokers to stop smoking, reduce withdrawal symptoms, reduce smoking satisfaction, prevent relapse, and evidence of efficacy established for smoking, but not equal to smoking for the smokeless tobacco. So if you look for the effect of pharmacotherapies overall, that is NRT, bupropion, and varenicline. So maximum efficacious drugs are varenicline and NRT. So the first line therapies that are available are NRT and varenicline. A combination of NRT and varenicline. It should be given to all the patients. So FDA approved those combination. Like first is long-acting NRT, that is patch, with the short-acting NRT, like gum and lozenges. So combination is more effective than the single NRT formulation and should be considered, especially in the smoker who are heavily dependent on the nicotine. And second combination is nicotine patch plus bupropion. Although there are some reports of using varenicline with NRT, but results are equivocal. So these two combination, long-acting NRT plus short-acting NRT for the heavy smokers, and nicotine patch plus or NRT with bupropion is approved. So there are certain interventions for smokeless tobacco. Like for the smokeless tobacco, behavioral therapy along with feedback of oral examination constitute the important intervention for these users. Meta-analysis of transdermal patch, gum, and bupropion studies for smokeless tobacco user indicate that these medications do not increase the cessation rate. Varenicline has also been demonstrated to increase the tobacco abstinence rates among the snus users. The similar finding also obtained in Indian studies done by Jain R and Janji S et al. In 2014. So to take home message that tobacco dependence is a chronic disorder, relapsing and remitting in nature that often require repeated intervention and multiple attempts to quit. It is essential to screen for and to identify tobacco use consistently in all the healthcare settings. Tobacco dependence treatment are effective and should be offered in multiple settings, both general and specialized, rural versus urban, and so on, as a routine healthcare practice. So, specific message is health professionals should ask all tobacco users to quit. First, to ask about the tobacco use and then guide them to quit. I'd like to acknowledge Professor Sonali Janji ma'am and Department of Psychiatry and Jodhpur for my presentation. Thank you.
Thank you, sir. So I'll start sharing my part of the presentation. So hope my slides are visible to everyone. And I'm audible.
Yes, ma'am. Yes, ma'am.
Thanks. Dr. Navratan had discussed how to assess and how to do the pharmacological intervention in patients who are having tobacco dependence. So I'm going to talk predominantly about the non-pharmacological intervention, which plays a very major role in helping the patients with tobacco dependence. Only giving pharmacological intervention and not giving non-pharmacological intervention will not lead to that much benefit as giving the combination therapy. So I would like to acknowledge Professor Sonali Janji ma'am. She had been my guide during my DM thesis, and she had always been helpful in the tobacco dependence treatment part. And I would also like to thank all my colleagues from the Department of Psychiatry at AIIMS Jodhpur who have been there to support. And even with the short notice, we were able to bring this process. So I would like to thank all my colleagues from the Department of Psychiatry. So coming to the non-pharmacological interventions per se. So as we all know, there are different interventions. One is a self-help intervention in which we give some pamphlets or we display some videos raising the awareness related to the harms of tobacco. There are certain intensive interventions. For example, motivational enhancement therapy or relapse prevention therapy, in which there are multiple sessions between a mental health professional and the patient, which involves extensive contact. And then we do specific therapies to improve the motivation of the person and help him to quit tobacco. So what I'm going to talk in this is a brief intervention, which any healthcare professional can do within a period of 3 minutes during the regular healthcare visit. This will help in a long way in reducing the tobacco use among our patients. So coming to brief intervention. So what is brief intervention? Brief interventions are practices that aim to investigate a potential problem and motivate an individual to begin to do something about his substance abuse, either by natural client-directed means or by seeking additional substance abuse treatment. This is the definition given by SAMHSA in the year 1999. So what are the goals of brief intervention when we think about tobacco? The primary purpose of the brief intervention which we do during our routine clinic visit is to help the patient to understand the risk of tobacco use and the benefits of quitting, to motivate them to make a quit attempt, and to refer them to more intensive treatments when needed. So what is the brief intervention usual method which we do in the case of patients with tobacco dependence? Just remember the remaining 5 A's and 5 R's. So 5 A's are for those patients who are ready to quit, in which we have asked, that is we ask all patients if they smoke or if they are using tobacco, advise all smokers or tobacco users that they need to quit, assess whether they are ready to quit, and then assist them with a quit plan or provide information on where they can go for the support, and then arrange follow, contact or referral to a specialist support. For patients who are not ready to quit, we have the 5 R's, which is we will be asking how much the tobacco use or the quitting is relevant to him. What are the risks of continuing tobacco use? What are the rewards of quitting tobacco? And what are the roadblocks or the barriers which a person thinks that can occur while they are trying to quit tobacco? And then we repeat the assessment. So I'll be talking about each step separately so that we will be able to understand it even better. So coming to the 5 A's, which is ask, So we have to ask about the tobacco use at every visit in the healthcare facility. So keep the question simple. Just ask, do you use tobacco, or does anyone else in your homes use tobacco, or they smoke around you? And all the healthcare professionals should make sure that they ask this history from all the patients, whether this person is a current tobacco user or former tobacco user or never tobacco user, based on which our intervention can be done. Coming to the next step, which is advice. So the way we are giving advice is equally important. So the advice which we give to the patients should be clear, it should be strong, and it should be personalized. So clear means we have to specifically mention that it is important that you quit smoking, or it is important that you stop using your smokeless tobacco right now, and we are there to help you. And then it should be strong. That is, we have to also emphasize that it is the most important thing you can do to protect your health now and for the future. And we, the clinic staff, are there to help you. And it has to be personalized. So we all know that there are a lot of harms for tobacco, but we cannot go and tell about all the harms to a patient in the busy clinic. And or even if we tell all the harms, the person may not be able to internalize it. So for a person to actually understand and actually take in mind that this tobacco use is harming me, we have to make it personalized. So it has been found that providing tailored or personalized information on smoking is more effective than providing standardized information. For example, if it is a female person who is using tobacco, we can say that it can affect your child. Or if you become pregnant, it can affect the pregnancy, it can lead to infertility. So that can be a motivating factor. Or if a person has a specific health problem, for example, asthma, then you can say that this your tobacco use can aggravate your respiratory problems. Or social factors. For example, if you're finding a person from lower socioeconomic status, we can use the finance, the amount of money he has to spend on tobacco, that is a motivating factor. So a useful strategy. So if we are not able to understand where to start, how to personalize in that case, you can just ask the patient, what do you not like about being a smoker? Or what do you think that you don't like about using your tobacco? Or how do you think tobacco has affected you or your life? Based on it, then you can give a personalized advice. For example, so if a doctor asks a patient, what do you not like about being a smoker? He says, I don't like the way it makes me cough. Then you have a clue that the person is concerned about his cough. Then you can go on from that. Yes, smoking does affect lung function, and it will get worse over time if you continue to smoke. Another person, when we ask, he's saying tobacco has not caused me any problem, but I have to spend nearly ₹100 per day. And you find that the person is from a low socioeconomic status, and then you go on with that. Yes, the cost of tobacco does build up. So let us find out how much money you are spending on it each month, and what can we do with the amount of money which you are using to buy tobacco. What can we buy instead of that? So this will motivate the person. This is kind of personalization. So coming to the third part, which is the assessment. So assessment, as Dr. Navratan already showed you, we have to assess the severity of nicotine dependence, one. So we can use a Fagerström test for nicotine dependence. So there are two scales. One is for the smokers, which is the plain version. The other one is a Fagerström test for nicotine dependence, smokeless tobacco, ST version, which is for smokeless tobacco. So you can use this to assess the severity of nicotine dependence. Higher the score, higher is the severity of nicotine dependence. And this you can show as a feedback to the patient that he is having this much severe nicotine dependence. So again, this slide had been shown by Dr. Navratan. This is the FTND, or the Fagerström test for nicotine dependence. The second part which we have to assess is the motivation to quit. How much the person is ready to quit at this moment, which we can do either by direct questioning or using some structured tools like readiness to change questionnaire. So we see what is the stage of change that the person is in now. That is, what is the patient's current motivation to quit, because based on which our plan changes. For example, in a person who is in pre-contemplation phase, he does not feel that the tobacco use is harmful at all, and he doesn't want to quit at all. In the contemplation stage, the person is a little bit dicey. He feels that maybe it is harming him. At the same time, he's also afraid that he may not be able to quit because of various barriers. So he's in a dicey situation. In the preparation stage, the person is willing to quit and he's ready to quit within the next 1 month. In the action stage, patient had started quitting, but he's in the first 6 months of staying quit. And in the maintenance stage, he has quit for more than 6 months. So based on this, our our goal for the brief intervention also changes. For example, if a person is in the pre-contemplation stage, we raise the awareness about the problems due to substance use. If a person is in the contemplation stage, we remove the ambivalence and help the person to shift towards quitting tobacco. Then if the person is in the preparation phase, we help the person to identify what are the changes he can do in order to quit. And if a person is in the action stage, we can then help him to implement the change strategies and eliminate the relapses. If the person is in the maintenance stage, we help the individual to develop the skills to maintain abstinence. And if a person had relapsed, then we help in coping with the consequences and determine what to do next. So coming to the fourth one, which is the assist. So for a person who is willing to quit, we can do just like Dr. Namratan said, we have to help the person develop a quit plan, which is equally very important, followed by helping patient in managing the anticipated challenges, and then recommend pharmacotherapy if appropriate, and provide supplementary materials like pamphlets or information leaflets, etc. So setting a quit date should preferably be done within 2 weeks of the contact with us. And in the T, we have to ask the person to tell his family, friends, and co-workers about quitting and request for understanding and support during the time he is quitting. He has to anticipate what are the challenges that can occur during the quit attempt, and he has to remove the tobacco products from the environment and make the home smoke-free. So how to help the patient in managing the anticipated challenges? Provide him basic information that when a person quits tobacco, then there can be withdrawal symptoms, which usually typically peak within the 1 to 2 months, 2 weeks after quitting. But sometimes a little bit of withdrawal symptoms may persist for months, which is called as protracted withdrawal symptoms. So this protracted withdrawals could include craving, it can include a negative mood or difficulty in concentration. And we have to also inform the patient that even a single puff can again increase the likelihood of a full relapse. And then we have to help the person in how to teach him how to manage the craving, which is very common in patients with tobacco use. So the skills for handling craving, which we typically call the 4 Ds, which is delaying. That is, if you're having craving, to delay the use of tobacco after 20 minutes or so. Distract yourself. That is, when you're having severe craving, then not to focus on the tobacco, but to focus on some other activities like watching a movie or talking to someone or going for a walk, etc. Drinking water. It has been found that when a person is tired, thirsty, or in hunger, there is a higher intensity of tobacco craving. So a person can drink water to reduce the intensity of craving, or you doing deep breathing exercise. Also, the person should be told to avoid hunger, anger, loneliness, and tiredness. So sometimes some professionals, they report that they are not able to avoid the hunger because they have to work from morning to evening. For example, the medical professionals, most often people skip meals and they are continuously in the work. So in that time, we can advise them to have a biscuit in their pocket or have some chocolates or some toffees, which they can grab within a minute or so in order to avoid the hunger. And when they're feeling excessively angry, to try to avoid those situations during the initial 2 weeks when the craving is even more, and try to remain with people and not to remain alone, and to avoid tiredness. That is, they have to take breaks in between their work so that they do not get extremely exhausted and again have an increase in craving. Also, they have to avoid the triggers that can trigger the tobacco use. For example, if they usually go to a place, go to the same shop where they are taking tobacco, they have to avoid that route. They can go in a different route. If a friend is offering tobacco, how to refuse. And if some people with smokeless tobacco report that if they quit smokeless tobacco, they feel as if there is some uncomfortable sensation in the mouth, as if something is missing. In that cases, we can ask them to take songs in place of tobacco, or to start doing some exercise or hobbies to distract themselves. So the last point is the 5 is arrange, which is we have to arrange for follow-up. So majority of relapse occurs in the first 2 weeks after quitting. So preferably the follow-up should be within 1 week after the quitting, and the second should be within the first month. And preferably it should be through personal visit in the clinic. If not, we can also talk to the patient through telephone or email. So during the follow-up, what should we do? For all patients, identify what problems they have encountered since the last visit till now in quitting tobacco, assess whether they have used the medications properly and whether there have been any problem, and then schedule the next follow-up. For patients who have quit tobacco, congratulate them on their success. This is equally important to keep on their motivation to remain abstinent. For patients who had used tobacco again during this period, remind them that relapse is a learning experience and try to review what situations have led to relapse, whether it was craving, whether it was peer pressure, and then elicit commitment and teach the patient or elicit from the patient what he can do if such situations occurs again and offer help. And in case if it is happening repeatedly, please refer them to a psychiatrist who can then offer more intensive treatment. So in those patients who are not ready to quit, what are we supposed to do? It is called the 5 R's. So here we do it after the assess step. After assessing, we are finding that in the motivation to quit, he is not ready to quit. We do the 5 R's. Then if we find that he is ready to quit, then we assist them using the pharmacotherapy, making the plan or arranging the follow. And if he is not ready to quit, again, in a non-judgmental way, we end positively. We can open door approach, saying, so saying that at any time if they want to quit tobacco and they need our help, they can come back to us anytime. So what are the 5 R's? So the first one is the relevance. That is, we ask them, how is leaving or reducing tobacco relevant to you, or how is tobacco use relevant to you? A person may say that I think smoking might be bad for my health, or tobacco use is helping me to relieve my constipation. So and leaving it might worsen my problems. So there are different ways a person sees it. So first we ask from the person, what is it? How is tobacco relevant to him? Then we try to find out what are the risks associated with continuing tobacco use. So what does he know about the risk of tobacco use to his health or her health if he continues the tobacco use? So if a person says, I think it can increase the risk of cancer, then we again personalize it and we go on with that. Yeah, that's right. The risk of cancer is many times higher among people who use tobacco. Sorry for the spelling mistake. So, and the next question is we ask, what are the benefits if you stop tobacco use or you quit tobacco? So then the person will say, I think it might reduce the risk of getting cancer. So then you go on, yes, and it doesn't take long for the risk to decrease, but it is also important that you quit as soon as possible. And after that, you then try to find out what are the challenges that the person is facing in trying to quit tobacco. Then we ask them, so the person can say what are the challenges which he faces. For example, he may say that he feels intense craving if he doesn't take tobacco. So because of which he's not able to control his use. Then we can offer him help with that by offering him nicotine replacement therapy, which can help to reduce the cravings. Or he can say that I'm having constipation if I don't take tobacco. Then again, whenever a person is seeing the roadblocks which they are facing when they leave tobacco, you offer them assistance in that. So you can tell that we can help with that. It is usually temporary, and you can take high fiber diet, lot of water, and there are certain medications like laxatives which can help during the initial stages. So after saying all this, then we repeat the same person. So now following the discussion, let's see if you think differently about your tobacco use. Think or feel differently about your tobacco use. So we again go and ask whether the person, what does he think about quitting the tobacco? And if you find most of the time the persons, when they get to know that it can lead to a lot of benefits and there are people who are there to help them in quitting the tobacco, their motivation to quit tobacco changes in a positive direction and they become ready to quit. However, if they're still not ready to quit, end the intervention positively by keeping an open door approach as mentioned previously. So to summarize, predominantly I wanted to talk about the brief intervention for tobacco cessation, in which the important 5 A's and the 5 R's are the predominant method in which we are doing the intervention. 5 A's include the ask, advise, assess, assist, and arrange. The 5 R's include the relevance, risks, rewards, roadblocks, and repeat. And always use a non-judgmental attitude and end positively. So thank you. And this is my mail ID. If anyone has a doubt, they can mail me this.
Thank you so much, sir and ma'am. This was indeed a very extremely educative and informative talk. I'm sure this will go a long way in helping us with our clinical decisions and helping patients with tobacco dependence. I now request the audience to ask questions, and I will now request Dr. Naresh Nebinani, sir, to moderate questions from the audience.
questions. Thank you, Dr. Navratan and Dr. Preeti, for comprehensive presentation and clarifying many doubts to most of people, because when such patients come, then it looks very easy, but sometimes it becomes difficult because things don't go as clinicians want. So in that way, it should generate a lot of interest. And if any question from there, I guess the chat box question has started. So is there any direct doses conversion for BD and cigarette? Sorry, where did we reach? Dr. Pranshu? Just go upside. Yeah. So is there any direct doses conversion for BD and cigarette in terms of nicotine gums or lozenges? Any one of you? I think Dr. Navratan has covered this topic. You or Dr. Preeti would like to say? And you can also read the chat box. It will be easy as ever you want to start.
So as I have mentioned that like NRT can be given as per the count of BD or cigarettes, like 1 to 24, up to 24 number, 2 milligram preparation can be used, and after 25 or more than 25, we can use 4 mg preparation. And dosing number of dose per day can be decided on the basis of symptoms. So up to 9 to 16 tablets or gums can be taken per day.
Dr. Preeti was saying something, is it?
Yeah, just to add on, so there is no direct conversion from the number of BDs and cigarettes to number of gums or lozenges, except for the thing, as Dr. Navratan pointed out, that if it is less than or equal to 24, we go for the 2 mg gums or lozenges. And if it is more than or equal to 25, we go for the 4 mg. So it is usually dependent on the amount of craving and the withdrawal a person is having. So you can always advise. See, one thing which we have to remember in NRT is we have to give a dose which is stable throughout the day. So we give it we have to give it on a regular basis, either as 1 or 2 hourly, rather than giving it on a SOS basis alone. SOS can be taken along with the 1 hourly or 2 hourly sessions, but you have to remember that there is no direct this thing. It depends on the person's symptoms.
The pharmacological management of smokeless tobacco. As you can again add, Dr. Navratan.
So as I mentioned that for the smokeless tobacco, generally NRT is not that much successful mode of therapy. Still, in our population, in routine clinical practice, we are providing NRT in the form of nicotine gum or lozenges. But varenicline, research on varenicline provided good results, but it is quite costlier than the smokeless tobacco. So looking into the patient scenario, we have to choose one drug from NRT or varenicline. As per research, varenicline has a good result in compared to NRT. So we can prefer varenicline. Other than the whatever the management Dr. Preeti has suggested, that is the primary management for the smokeless tobacco, non-pharmacological intervention.
Again, the part 2 of the question, what do we prefer? I guess my colleague will add here. But just to add that some data is also existing for nortriptyline for smokeless tobacco. People are using, and again, last 2-3 years, we have also tried to generate some experience with that molecule since it is available, and it is much cheaper where we don't have the facilities and the financial support for varenicline because some of the people are not able to afford. So low dose nortriptyline also does help in this in terms of pharmacological. But yes, how do we prefer or what do we prefer? It's more is a non-pharmacological coupled with some pharmacological management. I guess Dr. Preeti can add.
Thank you, sir. So in the case of smokeless tobacco, as Dr. Navratan had said, that varenicline has not been found to be that effective in case of smokeless tobacco. So we prefer either NRT or bupropion. NRT has been found to be good enough. Compared to smokers, it has been found relatively the percentage is less in the case of smokeless tobacco. With regard to nortriptyline, which are second-line interventions according to IPS, and they do not have FDA approval as of now. So it is still in a research phase. So predominantly we are preferring NRT along with non-pharmacological interventions. So non-pharmacological interventions have a very good role in the case of smokeless tobacco, as informed by Dr. Navrathan.
Any other question from any delegates? Because I'm able to see a couple of my faculty colleagues have also joined from medical, from nursing college, from public health community. So anyone want to add or anyone want to ask? If any of the participants want to unmute and then want to add or ask, then it is the right platform. And we have the experts, Dr. Navrathan and Dr. Preeti.
Hello. Good
Hello.
evening, sir.
Good evening, dear. From Rohtak, you are connecting to us. Thank you very much, Dr. Yogen Malik.
Yes, sir. Sir, I want to one newer concept emerging nowadays. Lung injury, basically the electronic, this electronic cigarette associated lung injury. So how common this is prevalent, and what are the, the precautions we should take while prescribing these electronic e-cigarettes or this type of tobacco use, because these are commonly associated with lung injury, a new concept coming from the Western countries, sir.
Thank you. Any one want to add? Dr. Preeti is visible.
Yeah. So e-cigarettes are actually banned in India. So you're not supposed to prescribe e-cigarettes to anyone. And the other thing is e-cigarettes is still in, it is still in the starting stage. And there are research which is showing both the ways. Like there are some research which are saying that e-cigarettes has helped a lot of people to quit tobacco. However, if you see, most of the persons who are taking e-cigarettes keep on continuing taking e-cigarettes. If we prescribe NRT, we are able to taper it off within 3 months, and then persons are able to remain abstinent, even though for a shorter duration. In the case of e-cigarettes, most of the time they call it as vaping instead of smoking. So they say that I have quit smoking, but they will be continuing to, they may be continuing to use it in the form of vaping. The other thing is it also has other chemicals, and there are studies, there are research which are showing that those chemicals, when they are burnt, they also have a little bit of cancer potential. So it is, again, research is still ongoing. It has not been extensively researched. So please abstain from prescribing e-cigarettes as of now.
Thank you. Just to add, people were taking or smoking e-cigarettes or maybe vaping because doctors were not prescribing in most of parts, and it was widely prevalent in many countries. But for a reasonable time now, India has banned because of these literature, which is emerging for almost last 4-5 years. It's a multi-billion market, pretty unregulated. And that's why the critique came, if it becomes regulated, then things are going to be very costly. That's why the both type of the proponents that e-cigarette does work, but it is not regulated. So many of the chemicals are itself carcinogenic. And I have seen, I guess, 6 years before in Germany, and then all these stalls, there was e-cigarette available wherever the souvenir shop or any grocery shop. Well, it was much not available in India at that point of time. But now many of the countries are now trying to take cognizance of this fact. But it was an invention which has gone with some problem. That's why the Indian government has banned. So that's why the doctors can't prescribe.
Yes, sir. Thank you, sir. But sir, during this, the tomorrow is the tobacco day, so we can spread the awareness among the healthcare professionals and other common men so that they can avoid e-cigarettes.
Sure, that is needed. Thank you, dear. Thank you. I guess the other questions have poured in the chat box. Safety and doses of NRT in adolescents, Dr. Navrathan. Dr. Navrathan, hope you are there. Might be some network issue. Dr. Preeti.
Okay, so I haven't gone into the literature specifically for adolescents, but yes, you can prescribe NRT to an adolescent also. So if a person is taking tobacco, it is even more harmful. And as we all know, that NRT would help the person to quit. So depending on the amount of tobacco, you can definitely prescribe NRT, which will help adolescent to quit tobacco.
Somewhere, as if we see the approval of this, then the trials are not much mentioning about this, but the literature suggests, since it is much less in terms of any type of harm compared to any tobacco products or e-cigarettes, that's why people are prescribing no ban on that. But yes, literature is available for adults, for including NRT. Next is which form of tobacco, BD or cigarette, oblique SMT, etc., is more difficult to quit? Is there any comparison?
Okay. Again, I did not go into the literature specifically to look. I have found that, clinically, I have found all the patients reporting difficulty in quitting. Those who are smoking as well as those who are on smokeless tobacco. So tobacco per se itself is a substance which it has been found that even if you try tobacco only once, it can lead to dependence in nearly 32% of the patients, which is the highest among all the psychoactive substances. And smoking, usually it has been found that it leads to a high faster because it is absorbed through the respiratory route, which has a higher surface area. So because of which the addiction also occurs faster in the case of smoking form rather than smokeless form. Regarding quitting, I haven't gone into the literature specifically who have difficulty in quitting. Because most of the literature had been on smokers, because in smokeless tobacco is something which is very common in India, and much of the literature is from the Western countries. So we would, I think I would go and look upon it.
Just, yeah, thank you, Dr. Preeti. Just to add that it is basically smokeless tobacco as the other comparison. The participant has cleared the question. Tobacco, sorry, cigarette or BD or smokeless tobacco. Somewhere it depends on many other variables than only what type of substance somebody is taking, including the duration, including the other facilitators as well as barriers and their motivation. By and large, in community, people feel that BD is less harmful than cigarette, while the researchers have said nothing of that nature data exists. Same is about smoking or smokeless form. But again, since your question was in terms of difficult to quit, that goes with many other variables. But in smokeless also, there are people who are consuming for decades, 10 years, 20 years, or 30 years in a way. Then again, it becomes difficult to have head-to-head comparison. 1. 2 is the other variables which are going to affect the quitting rate. 3, as Dr. Preeti mentioned, and again, this is the one different compared to other countries. In India, smokeless is much common, almost 2 times commoner than smoking form of tobacco in adult survey again seen. Compared in all the countries except 1 or 2 other countries where smokeless tobacco exists in some or other regular form. Otherwise, in most of countries, it is more or less, it is a smoking form. So that's why a lot of evidence is available for smoking, not for smokeless in the world literature. The next question is treatment option for nicotine in the pregnancy, nicotine use in pregnancy. I guess this is close to Dr. Preeti's heart, this topic. So
yeah. So in the pregnancy, usually the guidelines recommend that we should try non-pharmacological intervention as much as possible. However, if a person is not able to quit, even with a non-pharmacological intervention, there is no harm in giving NRT, because taking tobacco during pregnancy is much more harmful than taking nicotine. At the same time, do explain about the harms of nicotine in pregnancy, which predominantly includes that since there can be vasoconstriction, so it can lead to low birth weight, it can lead to premature labor. So that risk you can explain to the patient, but at the same time inform that tobacco can be even more harmful. So it is safer to quit with NRT than without NRT. So first should be non-pharmacological, and if it doesn't work, then go for NRT.
Thank you. Thank you very much for all the answers and all the questions to all the participants. So now my colleague, Dr. Neeti, is here. She is the expert in community health. And again, this topic, she's working into the community. And again, this is to be addressed at both the levels, because very small number of people are visiting to hospitals, that too for other problems, not for management of tobacco use disorders. So if we try in both the ways, hospital as well as community, or community and hospital, then it is going to impact much better. And again, one more thing which initially I said, and I learned that term last now for a few years. Then again, the role and beauty of opportunistic screening whenever anyone is consulting to any OPD, be it dental, be it pulmonary, be it medicine, be it surgery, be it gynae, be it dermatology. So wherever is the clinician is going to be aware that this tobacco use disorder is also existing, or tobacco use is also existing, then addressing even with a briefer 1 minute, 2 minute, 3 minute questioning, and then some or other nudge and helping the patient, then yes, the data exists that the sizable number of people think to quit more. And again, some proportion of the people, up to 1/4 to 1/2 people, do consider quitting with that small suggestion of 1 to 3 minutes. So that's why the briefer interventions have its own beauty. And one of the intervention, possibly you heard just now, it is a STAR intervention. I guess it was discussed, Dr. Preeti. STAR is,
Yes.
yeah, you are discussed. So in a way, there are many brief intervention, and the same suggestion my other colleagues sitting in pulmonary or other clinics have also said, yes, sometimes just saying to patient with empathy and some or other right approach, even just 1 minute, people quit. So in a way, that plus support of some psychological approach, and yes, whosoever can visit to psychiatrists or mental health professionals for those needs, then we are more than happy. Thank you very much. Since there's no questions, so I request Dr. Pranshu to pass the vote of thanks. And thank you very much for all the questions, motivation, encouragement, suggestions, and kind presence.
Thank you so much, sir. Now I would like to extend a vote of thanks to all those who contributed towards the success of today's program. Firstly, our esteemed director, sir, Professor Sanjeev Mishra, who supported this endeavor and took time from his busy schedule to be with us. Thank you, sir. Our department head, Dr. Naresh Nebinani, who motivated us for this program and guided us throughout. Thank you, sir. Our speakers for today, Dr. Navratan and Dr. Preeti, who enlightened us on today's topics and helped us learn so much more. Thank you, ma'am and sir. Lastly, but most importantly, I would like to thank all those who joined in today's program in the spirit of spreading knowledge and awareness, and also for their enthusiastic participation. Thank you all.
And a special thanks to Dr. Pranshu, Dr. Surendra, and Dr. Puneet for all coordination. They are the backbone of this program with the guidance of Dr. Preeti and Dr. Navratan, and all the faculty and residents and psychology colleagues of department. Thank you very much.
Thank you, sir.
Thank you.
Thank you all.
Thank you, Pranshu.
Thank you.